Okay, welcome everybody. We are going to go ahead and get started. Like I said, as you're joining, if you still see that poll up there, if you'll just take a minute and answer those questions. Hub members, I need you guys to answer those as well, if you will. If you'll just also enter your name and contact information in the chat, that would be fantastic. Today we are recording this session for educational purposes, and just so you are aware, if you don't wish to be recorded, go ahead and exit from the session. We would love some interactive case client participants, so please rename your profile and where you are from. We are an interactive community, so it really makes a difference for cameras to be on, so our presenters, and when we have case narratives, we can get to know each other. Just remember to mute yourself. Today, we will not be having a case presentation, but if you have a case presentation that you would be interested in sharing with us, please reach out and let us all learn from what everybody else is doing. We want to make sure that we protect any information, so please don't share names or contact information or where they live. If you're unsure of anything, go ahead and ask a hub member in chat. They are all the ones that have an asterisk in front of their name. So as you all are aware, as you've been attending these, there are key components of an ECHO session. So we want to build our community of practice with the members that are on this call, as well as a didactic speaker, and then we have a case presentation and feedback. We'd love for you to write in the chat in Zoom one reflection that you might learn from this session and what you might add to practice. That would be something that we could then highlight on some social media. We have pre-registration, so if you ever want to pre-register, go to Project Scope at USU to learn when we are doing our next session. To get credit for attendance, you need to fill out the evaluation that's sent to you. Always check your junk email in case you are missing that. I'm going to turn it over to Jared for a moment.
Thanks, Janelle. It's status quo at this point. We know the system well. Please claim CME today. The code for today expires at midnight. As of midnight today, you've missed your opportunity. So I will put the code here in the chat right away, and please go ahead and claim that credit. If you have questions about how to claim credit, please contact me directly. It'll be here in the chat for the next hour and a half. Thank you.
Great, thanks, Jared. If you have ever want to access any of today's information or information from the past, we do have our Canvas platform. If you have missed an invitation and need one, you can email Kurt Phillips or at Project Scope at USU to receive an invite for that. REDCap is our survey data collection tool. So you will have an email from them about the survey. Always check your spam and junk email folders. Again, just a plug for that case study. That's a great way to learn about real life situations. So if you have a case that you are interested in problem solving and learning some information from your colleagues, please feel free to reach out to us. We do have a Facebook and Instagram that we share information from our presenters, our next topics, and just to continue to develop that community of practice. So go ahead and follow us on that. If you haven't taken the poll, I'm going to leave it open for about 1 more minute as I introduce our amazing speaker today, Dr. Camille Fung, and I am just thrilled to have her share with us some information about neonatal abstinence and withdrawal syndrome. So without any further ado, I'm just going to turn it over to her.
Thank you, Janelle. This is the piece where see how the transition goes. All righty. Can you guys see my screen? Okay. Well, thank you so much again for the invitation. I am very honored to be able to continue to talk about this topic that is dear to my heart. And I hope that I can show you some newer information that wasn't presented last year. There are some slides that are duplicated, but I have tried to put in kind of newer information that has been published in the last year so that you guys can get some deeper look at what the evidence has been out there. So again, thank you so much for the invitation. And I have nothing to disclose. I wish I did. Oh, and one more thing, if you guys have any questions, feel free to put them in the chat and Kurt will interrupt me and we can get those questions answered. So today's learning objectives really are similar to what we saw last year, is that I still want to impress upon you the prevalence of neonatal opioid withdrawal syndrome. So we'll talk a little bit about that. There's been a change in terminology by the CDC and by the NIH. And so instead of NAS, they have now gone towards using the term of NOWS. So I do want to review the prevalence of NOWS, both nationally and in our state of Utah. Just know that many of the publications in the past continue to use NAS. So you will see that I will just use those terms interchangeably. And we'll again define the clinical features and why having withdrawal makes it so difficult for these babies to adapt and to function after birth. And also to illustrate some of the management protocols. And I think the sort of up and new coming thing for neonatal opioid withdrawal is this eat, sleep, console protocol that I'm sure people have heard about, and we'll talk about that in detail. So again, the culprit for all of us is the opioid pain relievers, right? And I'm going to abbreviate it as OPRs. So the US has experienced a surge in opioid use and opioid-related complications, as many of you are aware. From 1999 to 2009, there was a quadrupling of OPR prescription sales nationwide. And what I read recently is that the prescription has actually plateaued. Despite that, the opioid overdoses and overuses continue, which is very sad. So one statistics I can cite for you is that by 2015, there were 3 times as many prescriptions for OPRs that were filled than 1999, reaching more than 37% of US adults having access to OPRs. And in association with that, we saw a parallel increase in OPR-related treatment facility admissions as well as overdose deaths. So since 2011, deaths from OPRs have actually plateaued, versus deaths from heroin and fentanyl actually have grown exponentially. So as people get addicted to their prescriptions and then they have no more access, they are now turning to street drugs that are usually a combination. You think you're buying heroin alone, it's typically laced with other types of substances. Fentanyl is actually oftentimes in heroin on the streets. So a lot of people are actually dying from that. And in 2017, more than 47,000 Americans have actually died of opioid overdoses, outnumbering car crashes and firearms. So the CDC estimates that the total economic burden of OPR misuse alone is close to $80 billion per year. And this accounts for costs in healthcare, lost productivity, addiction treatment, as well as criminal justice involvement. As I mentioned last year, these are some of the most commonly prescribed short-acting opioids that you'll see are users. Codeine, hydrocodone, oxycodone. And if you were trying to compare their potency relative to morphine, codeine is about 1/10 potent. Hydrocodone is as potent as morphine, and oxycodone, which often is prescribed postoperatively, is actually 1.5 to 2 times more potent than morphine. On the converse, you have the long-acting opioids, which are methadone and buprenorphine, and you've probably heard of these drugs. These are used primarily to stabilize opioid withdrawal. Because of the increases in opioid misuse, as well as overdoses, not just in adults alone, but also in pregnant women, this has actually led to increases in neonatal opioid withdrawal syndrome, which again, abbreviated as NOWS. In addition, it actually have had increases in injection drug use, which has actually led to the spread of both HIV and hepatitis C. Hepatitis C really has increased substantially now with opioid addiction. Unfortunately, in the United States, there is actually no universal screening when a mom is pregnant for hepatitis C, even though many of the centers are now testing for it. It's kind of one of the prenatal labs that's now included. You get Hep B, you get Hep C. If a mother was infected with hepatitis C, the vertical transmission rate is about 6% of all infants. If the mother was co-infected with hepatitis C and HIV, the likelihood of transmitting hepatitis C is higher at 11%. And so some of the data that's coming out is that from 2009 to 2014, the rate of hepatitis C infection has actually doubled to 3.4 per 1,000 live births. And in the state of West Virginia is as high as 1 in 50 live births. So again, be cognizant that hepatitis C is surging in our community. So let's talk about neonatal opioid withdrawal syndrome then, abbreviated as NOWS. Like I said, it's replaced the old terminology of NAS. And NOWS really is used to describe neonatal symptoms occurring after in utero exposure to opioids alone or in combination with other non-opioid substances. If you had non-opioid substance exposure alone, the literature typically uses the term of neonatal discontinuation syndrome to exclude opioids. But I would show you data later on that many mothers are polysubstance users. Unfortunately, though, babies who have had in utero exposure to opioids, 55 to 94% of them will have some degree of withdrawal symptoms. This includes, mild symptoms to severe symptoms. So just know that having an opioid exposure, that baby is likely, the odds are they're likely going to withdraw with some degree after birth. And many of you who, deal with these babies right after birth are very, very familiar with the symptoms. And I have sort of categorized them into 3 big categories. One being neurological excitability. So some of their symptoms that they have include hyperactive primitive reflexes. They're irritable. They have, very distinctive high-pitched cry. They have sleep-wake disturbances, which makes it very difficult for them to actually sleep undisturbed for a period of time. They have hypertonia, tremors, and seizures are always something we most feared, even though it's relatively rare. The next sort of big system is gastrointestinal dysfunction. So know that, many of these babies, we hear that they are hyperphagic. They want to eat and eat and eat and eat. But having feeding difficulty is also a symptom. So some of these babies have to, after birth, they have to be supported by a feeding tube because they're just so discoordinated that they can't have a good suck and swallow. And then obviously they can have a lot of vomiting and diarrhea as well, which we have to try to control. And then the last big category would be autonomic signs. And these are things like fever, sweating, nasal stuffiness, and mottling. And why do we care about trying to manage all of these features is because having these symptoms put these babies at increased risk for failure to thrive. And so if you're not able to eat, if you're not able to sleep, if you're constantly crying, you're not going to be able to thrive. And that's what we're trying. I always get the question of, so how can we predict who's going to withdraw? How long are they going to withdraw? And how can we get them through this quickly? Well, I think it's actually very hard to predict the outcomes. Every baby is going to do it a little differently. And the reason is because there are many levels of metabolism. So, starting with the maternal drug history, mom can be taking illicit substances and prescribed substances. So all of those can have an effect on the central nervous system. The mother has her own drug metabolism, which then also affects how much net transfer of drug gets across the placenta. The placenta itself also has its own enzyme systems and can metabolize some of these medications. And then there is also the baby's own metabolism, which partly reflects paternal metabolism. So as you can see, it is very, very difficult to actually predict which baby will withdraw, for how long, how severe, especially in light of what we see with polysubstance use. And I'm going to just take maybe another 5-10 minutes to just sort of fly through the history for you all as to what has been going on nationally. There have been some landmark articles, which I'm highlighting here just to show you how things have really worsened from the late 1990s to now. So this is really one of the first articles that was published in JAMA of 2012 by Stephen Patrick. He is actually a neonatologist at Vanderbilt University, and he is very, very active in this field. He's always in front of Congress trying to argue for more funding for this population, trying to do better with mommies and babies. So if you're ever interested in following his work, he's a really, really nice person to get to know. So what he did back then was he looked at a national database of all the hospitals across the United States and tried to estimate the rate of NAS per 1,000 hospital births in many, many of these hospitals. So in those 9 years, what he found was that there was a threefold increase in NAS during the study period, translating to about 1 baby born every hour back then in the US who was suffering from NAS. Concurrently, the maternal opioid use in that study period increased by 5-fold. No surprise. And then he broke down some of the mean hospital charges and length of stay. And as you can see here that I highlighted in red, from the years 2000 to 2009, the average length of stay for babies suffering from NAS was about 16 days. Whereas if you were a regular US birth, whatever that means, your average length of stay is about 3 days. So definitely these babies are staying in the hospital for much longer. And at a cost of quite a lot of money, right? A regular birth is $6,600 to $9,500, whereas these babies are spending up to $40,000, $50,000 per hospital stay. And when they accounted for inflation, these charges remain significant. And then the question is, who are the people paying for all of these hospitalizations? It's really Medicaid. So all of us as taxpayers are bearing a part of this burden to manage these babies while they're having their trouble. So if we fast forward time to 2015, this was also another article that was published in the New England Journal of Medicine. Again, trying to impress the nation, I think, as to how prevalent this problem is for mommies and babies. So when they looked at the years of 2004 to 2013, there was a rise in NAS from 7 per 1,000 hospital births to 27 per 1,000 hospital births. And again, increasing length of stay for these babies over time to, more than this 2-3 days that are staying for a regular delivery. And the total number of NICU days nationwide that were attributed to NAS actually increased from 0.6 to 4%. And there were 8 centers reporting more than 20% of their NICU stays were because of babies with NAS. Can you imagine 1 in 5 in the hospital suffering from NAS? That's a lot of babies. And in this article, they estimate that instead of 1 per hour, now every 25 minutes, a baby is born with NAS. Again, further data marching over time. This is another study by Winkelmann et al. Looking at almost 13 million hospital birth dates from the years of 2000 to 2014. Again, they found that Medicaid covered the majority of these babies with NAS, increasing from 73.7% to 82%. And Medicaid infants with NAS tend to be more likely to be transferred to another facility and with longer length of stay. And I think the transfer is because many of these babies are born in probably a level 1 nursery, and they end up having to stay for longer. And so they end up having to go to a higher level of care. And then adjusting for inflation, again, hospital costs are enormous for this population. And in this article, they're now estimating every 15 minutes, a baby in the US is born with NAS. And this is really the last article that I wanted to show you that's just published this year in JAMA. I think as you will see, some of the data are encouraging, some of them are not. They again looked at national and state variation in NAS and maternal opioid-related diagnosis in the years of 2010 to 2017. So pretty recent data. And they looked at a whole bunch of hospital discharge records from community non-rehab hospitals in 47 states and Washington, DC. And what I wanted to show you here is that, before I highlight, so if you look at this table, what they're trying to show you is that, so the first 2 columns represent neonatal abstinence syndrome. So in their cohort that they looked at, 0.7% of their hospitalizations was attributed to NAS. And then if you look at the next 2 columns, which is relating to maternal opioid-related diagnoses, about 0.8% is relating to maternal opioid use. And so about 0.7 to 0.8% of all the hospitalization across the United States in that study period was due to opioid use. And who are the people affected? And this is what I wanted to show you. These are interesting data to me. So the non-Hispanic white females and babies are the ones who are impacted the most by this diagnosis. And also of interest is that mommies who are between 25 to 29 years of age were the ones that were most common with a maternal opioid-related diagnosis. Again, Medicaid insured families are the ones who are having this problem. And the families from the lowest income quartile, basically less than $44,000 per year, median household income, are also the ones that have the highest incidence of both NAS and maternal opioid-related diagnosis. And if you look at how they sort of break down zip codes and quantifying them as urban versus rural. So the large metropolitan cities are the ones with the highest numbers in this cohort. So if we actually focus further in on just NAS alone, across the years of 2010 to 2017, which is the top row, you can tell that, yes, we are still increasing over time with our diagnosis of NAS. And what I wanted to show you is that I know the previous slide, I told you that the large metropolitan areas are the ones with the highest incidences. However, if you actually look at the small metropolitan cities, even though they don't have the highest rates, they actually are increasing quite quickly across the years in terms of how many of their babies are suffering from NAS. And even more importantly, though, I think is the non-metro and the rural areas that are even having a faster increase than what we see in the urban areas. So this is the similar analysis looking at moms, looking at maternal opioid-related diagnosis, again, paralleling to the NAS, the incidence across time has increased. And again, just grabs my eyes that the rural cities are the ones with the highest rate of maternal opioid-related diagnosis. And then if we want to look at length of stay and cost, this is why I was maybe a little bit encouraged, is that over the time from 2010 to 2017, we actually are seeing maybe a sort of a plateau or even a slight decrease in the median length of stay over time. And I think we can sort of speculate why this is happening. I think many centers, nurseries are more aware of this problem, and they're having protocolized algorithms to help get these babies through. So I'm hoping that that's actually a positive thing. The cost also hasn't changed too much. I would say it's probably, again, plateaued over time, but it's still a very, very expensive diagnosis. And I know some people don't do well with numbers, so I thought I'd show you the heat maps, kind of reiterating the data of what we just saw. So the map on the left is, again, NAS per 1,000 hospital births in 2017. The darker you are, the worse you are. So West Virginia, which is very, very dark maroon in color, is having the highest NAS per 1,000 hospital births. And then if you look at the percent, so A is the actual rate per 1,000 births, B is more the change. Again, Oklahoma here and West Virginia are the ones having the most trouble. Similar maps for moms for maternal opioid-related diagnosis. Here, Vermont seems to be the culprit here for maternal opioid-related diagnosis per 1,000 deliveries, and then the percent change. Arizona is sort of jumping out. So is Texas, not Texas. What is next to Texas? I'm having trouble with my geography here. So Arizona, and then
New Mexico.
New Mexico, yes, thank you. New Mexico is also having lots of issues with maternal substance use. So lastly, another paper I wanted to show you, this is actually coming out of our own University of Utah data, which is interesting just to show you locally what we're also experiencing. So we looked at the hospital outcomes of infants that are more than 34 weeks of gestation, exposed to opioids alone or polysubstance. So polysubstance really was opioid plus one other non-opioid substance. We looked at the median length of stay, length of treatment, the percentage of babies who needed pharmacological treatment, including adjunctive therapy. And this spanned from April 2015 to May of 2018. So we looked at these 3 years because really that was the time when our own nursery implemented a protocol to try to help standardize the care. And so we really wanted to see how we fared in those 3 years. So we had 175 babies, and only 19% of the babies were opioid exposed alone, versus 81% of our cohort had more than had opioid plus one other substance. and about half of these moms smoked. So this was actually the table of the demographic data that we found, just to show you many of our babies are actually managed in our intermediate care nursery or newborn nursery. So 80% of the babies are trying to stay with moms and trying to not be separated from them. But if they do have a medical issue, they do get transferred to the NICU, and only 20% of the babies actually do end up coming to the NICU at the university. About half of mommies are breastfeeding at discharge, which you know, it's okay. Of course, being a baby-friendly hospital, we would have liked to have a higher percentage. And then just to show you the prenatal exposures, right? Because I think that's important to know. Again, 81% of our moms and babies are doing more than one substance. And here's a list of all the exposures: short-acting, long-acting opioids, nicotine, stimulants, antidepressants, cannabinoids. So THC really hasn't gotten too crazy in our population. Sedatives, anti-epileptics, and antipsychotics. So really a whole host of different exposures that could potentially impact the central nervous system in the fetus. And we looked at some of the outcomes. So the link, I think it, you know, when we did this study, anecdotally, we thought moms who had polysubstance exposures, the babies would actually have more issues and would stay longer. And we didn't actually find that. The median length of stay was really the same. So were the number of infants who actually required a pharmacological treatment. That was similar. Their length of treatment, if they got on medications, was similar. And babies who required additional medications in addition to morphine was also similar. So this really kind of opened my eyes that what this means to me is the opioids really is the substance that is driving the length of stay in these babies. And even though we might feel that having more than one substance is going to commit them to a longer length of stay, this really didn't bear out in our analysis. And because the opioid seems to be driving the hospitalization, we also looked at, is it the short-acting opioids, is it the long-acting opioids, or is it the combination that is making these babies stay for longer? And the only thing that became significant for us was that if you are actually on both, if you have a mom on methadone or buprenorphine, but she's not well managed and she's relapsing into a short-acting opioid, those are the babies who end up needing more pharmacological treatment. And so I think that makes sense. And so this just, again, speaks to how not being well managed and having a relapse is also affecting the infant post-delivery. And then we also try to be fancy and looked at individual drugs, what happened to them in terms of affecting length of stay. So if the moms only used a short-acting opioid, or if she used an stimulant, it actually decreased the length of treatment. So again, not advocating that we have moms get on these drugs to decrease the length of treatment, but I thought that was actually interesting. I think it speaks to the short half-lives of some of these medications, and that's why they're actually getting out of the hospital sooner. On the converse though, if a mom is on maintenance-assisted therapy, it prolongs all of the outcomes: length of stay, need for pharmacological treatment, length of treatment, and need for adjunctive treatment. So again, not advocating that we don't treat mothers well with their substance use disorder, but just know that that baby is going to need to stay in the hospital for longer and potentially need more treatment. Same thing goes with the use of antidepressants and anti-epileptics. They're both prolonging baby's length of stay. So I thought that was interesting. So now that we've sort of completed the epidemiology of things, let's talk a little bit more about management as well as some of the long-term neurodevelopmental things that I'm sure you guys are interested in. So this, the American Academy of Pediatrics back in 2012 published a report recognizing the skyrocketing increase in NAS. And so they put out a statement that every nursery should have a policy for assessing maternal substance abuse, as well as a standardized plan for the evaluation and management of infants with withdrawal. And I just wanted to kind of highlight your attention that this AAP clinical report was just revised last year in 2010. So if you wanted a more updated information on what the AAP is advocating, you can refer to this bolded and underlined clinical report. As you can see, Patrick et al. Is the one of the co-authors. So again, he is very, very active in this field. This is the algorithm that we use at the University of Utah, as well as Intermountain Healthcare. And I think you guys saw this last year, so I won't belabor that. For non-pharmacological care, this really is now become the forefront of NAS treatment. And we will talk about Eat, Sleep, Console, which is sort of the epitome of non-pharmacological care. So this should always be the first line of treatment for any drug withdrawal or discontinuation syndrome. And oftentimes, if a baby only has non-opioid exposures, we're not even advocating that you use any kind of scoring system. But if the nurses do want to gauge severity, that is fine. And we also need to put the infant's behavior in the context of their exposure. So if a baby has been exposed to a lot of methamphetamine, which is a stimulant, they're going to be irritable. They're going to have a high-pitched cry. They're going to be hypertonic. So all of these symptoms, do they make sense for the actual substances they have been exposed in utero? And I think the key, this is really, really a key point for non-pharmacological care, is we must educate our caregivers, moms, dads, grandmas, whoever's coming in, about how to minimize withdrawal severity for these babies. Both learning about the signs of exposure as well as common techniques that work for that particular infant. Some of the things that people do in the nurseries for non-pharmacological care are things that you're probably already aware of. Swaddling with soft blankets, having a quiet, dark environment. Sometimes people are advocating for frequent feeding of hypocaloric formula, which is a little bit controversial in this current setting. Trying pacifier, kangaroo care, we know works really, really well. But again, you need the caregiver to be at the bedside for that. If you were, a care team in the hospital organizing care, so you're examining babies at the same time to minimize handling. Swings can be helpful, but sometimes may also be too stimulating for these babies. So you just have to figure out what works and try to cluster care and daily examinations together. Basically determine the level of stimulation that the baby can tolerate while they're having these withdrawal symptoms. This table that I found in actually that AAP clinical report article that I was telling you guys about, it made a lot of sense to me. Even for non-pharmacological care, we can't just look at the infant neurobehavioral functioning. We also have to take the mother's functioning into account, as well as the environment and the provider, meaning the caregivers, including the care team, the medical care team. So I think we just have to be sort of all-encompassing to understand how we behave as a group is affecting that infant's withdrawal signs and symptoms. So they go into some detail explaining that, which I thought I should just highlight if you have a chance to read that clinical report. So breast milk feeding is actually the most studied non-pharmacological intervention that we can provide. So is the mom's milk safe for the babies? Infectious disease risk is one arena that we have to sort of assess. Checking the mom's prenatal labs. HIV positivity is an absolute contraindication in high-income countries. That may not be the case in low-income countries. Again, checking the drug screens for polysubstance use. Currently, there is lots and lots of controversy about ability to use breast milk with marijuana exposure, and you guys feel free to throw me questions about that. There is no consensus because there is no good long-term follow-up studies, but even now without definitive studies, the American Breastfeeding Medicine Society, ACOG, and AAP, everybody is still discouraging the use of breast milk that has no marijuana in it. The American Breast Milk Society even published consensus breastfeeding guidelines that suggest that breastfeeding should be encouraged only if the mom has had no relapse in more than 90 days, but discouraged if there's been a recent relapse of less than 30 days. And then a question I also get oftentimes is it safe for moms to breastfeed with methadone or buprenorphine? Yes, it is safe, but know that they do not prevent withdrawal. Some studies will say having that tiny little bit of methadone or buprenorphine will actually help with the babies, but just know that the concentrations in breast milk overall are very low and not related to maternal dose. Lastly, sometimes we get thrown all these different things that the mommies are on and we don't really know if it's safe or not. So I would encourage people to refer to both Dr. Hale's Medications and Mother's Milk book, or he actually has a website now online that is updated very frequently, or the NIH updates a database called LactMed, which is also a very, very good resource if you want to know if a mom's taking something and whether that's safe for breastfeeding or not. So I just want to fly through some of the opioids and how do you know when a baby's going to present withdrawal, just to kind of give you an idea of what it looks like and when they would present with symptoms. So short-acting opioids are the ones we talked about today: heroin, oxycodone, hydrocodone, fentanyl, all of those things. Those are short-acting opioids. And oftentimes they were prescribed for a legitimate reason, but everyone's addiction level is a little bit different. And so sometimes for a legitimate reason, the person still gets addicted over time. And as opioid dependent users have no more access to prescriptions, they will sometimes go to street drugs and to try to temporize their withdrawal symptoms. And again, like I mentioned before, oftentimes what you get on the streets is not pure anything. So be aware of that. And as I've shown you, polysubstance use is still by far more common than just pure opioid substance use. In terms of withdrawal, when they would present, a very, very old paper in 1957 had 13 cases. And the first AAP clinical report actually took that and made a statement that if more than 1 week has elapsed since the last maternal dose and delivery, the incidence of NAS is relatively low. Then we have the long-acting opioid methadone. This has remained the standard of care for opioid addiction treatment in pregnancy since the 1970s. It's typically given under medication-assisted treatment program with very, very strict rules. And we can certainly talk about the pros and cons of methadone clinic that's a topic, I think, on its own. Buprenorphine products are really the long-acting treatment that is becoming more and more favorable than methadone, again, because oftentimes methadone has to be dispensed in the assisted program. It's very prohibitive for many moms to actually get to these methadone clinics. So if you have a provider who can actually write a prescription for buprenorphine, it becomes easier access for these moms. So buprenorphine is what we call a partial mu opioid receptor agonist. What the heck does that mean? So basically, for methadone, let's compare it to methadone. That is a full opioid receptor agonist, meaning that once it binds to the receptor, it will elicit its effect at the doses as you titrate it. The more you give, the more effect you have. But with buprenorphine, you get a dose-dependent effect at low doses. But at high doses, you actually reach a ceiling effect, meaning that you don't gain anymore by going higher on the dose. It also is a partial kappa opioid receptor antagonist. So it doesn't just have an agonistic effect, it also has an antagonistic effect. on different opioid receptors. Buprenorphine comes in a few flavors, and you might hear about these. So buprenorphine alone can come in a brand name of Buprenex or Subutex. These are just buprenorphine alone with no other additives. However, what I hear more commonly is that moms are being prescribed Suboxone, which is buprenorphine and naloxone in a 4:1 ratio. And the dose of naloxone in this pill is actually very low, and naloxone itself is not very well absorbed orally. And so taking it by mouth, it's okay. So why do we even have it in there if it doesn't work as an antagonist? Well, it actually tries to prevent pill diversion. So if someone stole that mother's pill, the Suboxone, and they crush it and they try to inject it into their veins, you would actually get an immediate withdrawal because the naloxone goes into the vein directly and precipitates a withdrawal. So it's really a mechanism to prevent drug diversion. And I think a lot of buprenorphine prescribers nowadays are prescribing Suboxone for that effect. Buprenorphine during pregnancy has been well studied. It doesn't prevent NAS, it still causes NAS, but tends to have shorter and milder courses, and maybe as a result of lower opioid equivalent dose. So why do we even use drugs, right? We should just stick with non-pharmacological treatment at all times if we can. Of course, that should be the mainstay of therapy, but sometimes the withdrawal symptoms are so severe that doing non-pharmacological means is insufficient. And so the reason we use medications to treat is really to try to relieve symptoms that are interfering with their normal living. So you're trying to achieve physiologic stability. You're trying to make sure they can eat and gain weight, the ability to be consoled, and the ability to be able to sleep. And even more importantly, to improve the mother-infant interactions and bonding. If a baby is freaking out, that mother is not going to be calm. And so sometimes you do need to use pharmacological treatment.
Dr. Fung, can I take you back just a slide or two? Edwin asked, should we discourage Suboxone during pregnancy?
I would not discourage Suboxone if that is the medication that's been prescribed to treat the substance use disorder. I think sometimes mommies, when they are pregnant, they want to stop everything because they want to make sure they're doing the right thing. But I think it comes at a high cost if you're not managing the substance use disorder well. So I don't know in what context that mommies shouldn't be getting it. I think if anything, we should lean on being able to take it if the mom has a substance use disorder. And then just to kind of throw out for you what kind of medications that we do use, morphine really is the mainstay. In the US, I think 80% of nurseries rely on morphine. You just have to know that long-term morphine use, however, can actually give you the opposite effect. It can actually lead to dysphoria and restlessness because over time in older infants, the liver actually starts to make a metabolite called morphine 6-glucuronide, which is actually, it makes you kind of crazy. So try to get them through their withdrawal non-pharmacologically. And if you have to use morphine, we try to get them off quickly as well. Other drugs that are in use, methadone would be one, is used less frequently, and I would say even buprenorphine is used even less. I know people are trying to use buprenorphine more often, but it has its issues as well. And buprenorphine really has only been done in clinical trials, and it has a high alcohol content, so that's why it's been difficult to actually administer buprenorphine in neonates. Both methadone and buprenorphine, however, have shown to reduce duration of treatment and length of stay, but again, they've only been given in rigorous study protocols and with only women on opioid use disorder treatment programs. And so people do question the generalizability using these medications. If morphine is insufficient, in our hands, we use clonidine or phenobarbital. And again, I don't need to bore you with how we do this, but these are the adjunctive therapies that we do give if morphine is not. We'll get to length of hospitalization and treatment. People will ask me, well, how long will this baby stay for? I think it's not how many days or how things are, what a prescribed number of days should be. I really think that the disposition is highly variable, and we should focus on the baby's ability to sleep, eat, gain weight, and be cared for by a reasonable layperson after withdrawal symptoms. The severe withdrawal symptoms are managed. And also a piece that we don't have time to go over is the safety of the home environment. I think this also needs to be done early. Oftentimes, DCFS is involved, and they may even be court proceedings that have to be tackled before a baby is discharged. So assessing home safety is also important. Dr. Hall actually said, this is kind of funny, no matter what you do, following a standard treatment protocol with stringent weaning guidelines in itself will reduce the duration of opioid exposure in length of stay. So just doing something systematically, that makes sense, right? That it would also alone help with reducing length of stay. So I think I'm going to spend the last little bit, I don't know if I've drone on for too long now, but the last little bit is kind of the exciting piece with neonatal opioid withdrawal is sort of this infamous eat, sleep, console protocol you guys probably heard about a lot. This really came out from Dr. Michael Grossman. He's at Yale. So back then, in Connecticut, they were seeing a rise in NAS. And so in February of 2010, he assembled a multidisciplinary team and really instituted some key measures and changes some of their practices over a 5-year period to see if they can actually improve these babies' length of stay and get away from needing a lot of pharmacological use. So they standardized their non-pharmacological care, coupled with empowering caregivers and mothers to be at the bedside holding the babies. They have a development of a novel approach to assessment. So rather than using scoring with a number, they're focusing on different parameters to assess how the baby's adapting. They are only using morphine as an as-needed basis, and then they're making all the babies bypass the NICU and go into a room with their moms. So it's called eat, sleep, console because those are the 3 things that they care about. They don't care about hypertonicity, tremors, crying. They just care about is the baby eating, sleeping, and consoling. So what they define as being able to eat is the baby has to be able to breastfeed effectively for more than 10 minutes and take at least an ounce from a bottle per feed. The baby has to be able to sleep undisturbed for an hour. And if crying, he or she must be consoled within 10 minutes. And if all of these things fail, then you would think about pharmacological treatment. But even if they don't do well the first time around, you will basically meet as a care team with your nurses, with the moms, and figure out which piece is not being done well from a non-pharmacological standpoint. And then you forge ahead and do it again. So you're doing these assessments with the mothers involved, with the nurses involved, with the caregivers, and basically just trying to make sure that you're hitting those landmarks of eating, sleeping, and consoling. And what they found was that they did this on 287 infants. Their average length of stay was really high at the beginning. It was 22 days. They dropped it down to almost 6 days. And the proportions of methadone exposed infants treated with morphine decreased significantly, as you can see. And the cost also decreased significantly. And in their short-term assessment, there were no adverse events and no readmissions. So I'm happy to say that the University of Utah, we're actually now one of the sites for the NIH-funded ESC study. So this ESC protocol is very appealing because of its ease of use and it's simple. However, it's only been done outside this Dr. Grossman's QI initiative project. So we do not know the generalizability, which is why it needs to be studied. And the NIH is sponsoring this trial, including 26 sites across the United States, and we're one of them. So having this Eat, Sleep, Console protocol, really, some of the questions that have come up is the improved length of stay attributed to the approach, or is it bed adherence to non-pharmacological approaches, which also reduces the length of stay? So that we don't know. That's why we're studying it. And I think the more important question, and for many of you as well, is that we don't know how these babies do in the long term that are only managed primarily with non-pharmacological approaches. We don't have any follow-up data. So this trial includes a 2-year follow-up. And there are many, many surveys that sample the mom, the baby, how everybody's doing post hospital discharge. And there is a Bailey exam that will be done at 2 years of age to assess the neurodevelopmental outcome. So these are actually the lead study investigators from the University of Vermont, Louisville, and Cincinnati, who are driving this ESC approach protocol. And again, just to reiterate some of the current challenges limiting widespread adoption, even though I would say the East Coast, many centers actually have adopted it and are not participating in the trial because the findings were so significant that people just went ahead and adopted it in their nurseries. But I think we should look at it systematically. So it has only primarily been implemented in hospitals where a large proportion of the moms are receiving medication-assisted treatment, so methadone or buprenorphine. Unfortunately, this is not the case for us in the state of Utah, so I think it is important for us to participate. Also, the potential effects of the ESC care approach on infant safety and infant and family well-being after discharge are unknown. So again, it's important that we study it. And I think the rigorous study of this care approach is really needed to establish safety, efficacy, and generalizability for all infants with NAS. So for the study, their primary hypothesis is that babies evaluated for now, this ESC care approach will reduce the length of stay by about 4 days compared to the usual way of managing. And their secondary hypothesis is that this ESC care approach will actually improve infant neurodevelopmental outcomes and as well as family well-being, which will be assessed by surveys as well as the Bailey exam. We're in block 5 at the University of Utah, so there are 26 sites broken down into 8 blocks. And basically what we've done is that we just continued usual care for the first part of the trial. Recently, we went through a very rigorous training session on how to do ESC, and we have just switched over to doing it now since the end of August. So it's, and I think Banu's on this call. Banu is my pediatrician on the nursery side, who's helping me do this trial. And I'm sure she can, Jeff, if you guys have questions for her, she can speak up on how it's going for now. But it's you know, anything that's new, it's it's a learning process. But hopefully we are minimizing the use of pharmacological therapy as a result. The potential impact, I think you guys are probably appreciated by now. This will provide a very strong evidence to prove efficacy, safety, and generalizability, provide long-term outcomes for these babies, and provide data for the first time on family well-being, which has never really been studied in the past. And a couple more slides left. This again came out of that new AAP clinical report, which I love. There should be a discharge checklist on what needs to be done to ensure that the baby is ready for discharge. And I think we forget these two very critical pieces. So if you look down at this checklist, right, of course you cannot have symptoms for 24 to 48 hours. You have parent education, you have scheduled a follow-up visit with the pediatrician. But two pieces I think we always forget. Early intervention referral. We just forget that. I don't know why. These babies qualify for early intervention referral, and I just don't think we remember that. That's one thing we must do better. from the hospital side. And I think having a home nurse visit referral is also something we don't do well with. We just forget. But sending a home health nurse to make sure that the family is coping after discharge is critical, I think. And so I just want to highlight those two things on this list that we can improve from the hospital side. In the end, outcomes, right? How are we faring with these babies? Well, I think it's really, really difficult to disentangle the short and long-term effects of exposure to opioids with other substances. And I think these families have lots and lots of social economic factors that we don't account for. We have systemic racism, maternal, physical, mental health that is not well addressed. We don't even talk about genetics or epigenetics, their nutritional status, their environmental factors. I think all of these in concert do affect the infant development, independent of their substance use disorder. So I think it's difficult to really figure out which piece is from the opioid exposure alone. However, all babies with opioid exposure, regardless of whether they needed pharmacological therapy or not, are at increased risk for developmental alterations. And so we should refer them to early intervention, and again, consider referral to home nurse visitation programs. And this is something I learned, right? They actually, you guys have an early Head Start program targeted for pregnant women and infants up to age 3. Again, I think we just don't think longer term enough. We just want to get them out of the hospital and kind of good luck. No, you really should make sure that they're getting their follow-up and referral to maximize their development. And these are other resources that I found that I think will be helpful from both national and local resources. Thank you. That's all I have.
That was such a great presentation, Dr. Fung. I just really loved it. And I loved that plug of the early intervention because that is a critical piece in it. We had a presenter that shared some information about just that relapse that moms go into within the first year of the baby's life, and said that early intervention piece becomes a really valuable tool. So I love that. I am going to participants just throw up the final poll, and feel free to unmute yourself and ask questions. My chat went away, so I can't see. Pat has her hand up.
A hand up rather than interrupting. I am really interested in who gets the training. Are they nurses? Who gets the training?
You mean for the ESC?
Correct.
Yeah. So when we did it at the university, it is primarily nurses.
Okay.
And then and again, I think Banu's on this call, right, Banu? We definitely trained some what we call Gold Star champions. So they're typically charge nurses, people who are going to be around a lot because the nursing staff, you know, ebbs and flows a lot. And so we have some Gold Star Raiders that they were the first learners, and then we're just trying to sort of disseminate that to the rest of the nursing group.
So your OT-PT speech staff were not involved in?
Yeah, unfortunately, we only had, I think we were funded to only pay, quote unquote, 6 trainees from the NIH. You know, they held a 3-day training session for about 6 people per site, because you know they're trying to train 26 sites of people, and then it's really up to each individual site to spread. So I don't think this precludes OTPT, but since it just started and we're in the spreading phase of making sure that other nurses are also being taught. So yeah.
Thank you.
Somebody else asks another question, I'm just going to say, please take a minute to answer the poll question. the last question, number 6, actually needs to have an answer in chat. There's just not a way to do an open-ended question in Zoom polling. So. Other questions or insights now that I interrupted everybody's thought process?
Anna, do you want to jump in and tell them a little bit more about ESC if anyone's interested, since you're intimately involved?
Yeah, that'd be great.
Yes, hello. I just wanted to, I think it was a really great overview. I think the only things that I have to add are that we did the majority of our training with nurses and myself, and have each person who participated in the NIH training has then trained some more people. And so what we have done is use that initial training to extend a little bit further. And it's gone really well so far. And it's been nice for the physicians because I think it extends our like big picture approach that we've done already. And it is a really great way of approaching the babies holistically, which has been wonderful. So all good things from our end.
Tiffany, go ahead. You have your hand up. Oh, but you're muted, Tiffany.
I forgot.
That's okay.
So my question is this information being utilized by people who are in very small communities? So I'm down in Emery County, and our little girl that we adopted, her mom, she tested positive with the umbilical cord testing for amphetamines, methamphetamines, and heroin. And we didn't know what we were doing, but she was released from the hospital on day 2. And so her withdrawal symptoms were intense, you know, and so I've always felt like there was more that should have been done to help her through that situation. So it's just out of curiosity. I don't know if there's anybody that knows or if there's any test studies done, but are people in rural communities hearing about this? Because I don't know, it's a big issue for me anyway.
Yeah, and I think, well, that's why, you know, one reason to have Project ECHO is to try to disseminate some of that information. But you're right. I do feel that the rural counties are not getting the same information as urban counties. And of course, you know, me being in an academic center, it's easy for me to speak because this is what I do. This is sort of my role. But it is true. And I actually partnered with the Utah Department of Health back in 2013 to 2018. I just stepped away from my role with them. My role back then was to really spread the education and take the protocol that we came up with that was adopted by the University of Utah and Intermountain Healthcare to try to spread it to the other sites in the rest of the state. But it was difficult because it was one of me. We created a website and the Department of Health website. It's under UINC, Utah Women's and Newborn Quality Collaborative. So a lot of the stuff that you can learn about how to treat babies with NES are on that website. But I used to travel all around to try to kind of spread that protocol.
Okay.
It's been difficult for me alone to do it. And
right.
You know, we don't have funding. And so it's just my time. But if you go to the UINC website, there's a lot of stuff that we have posted as resources that you can tap into. And you can always feel free to reach out to me if you need me to give another webinar over Zoom. You know, now that Zoom's taken over our lives, is that good and bad, right? It's easy now to just arrange a Zoom meeting for me to talk for an hour or two and give you some of this information. So
Wonderful.
the one thing that pandemic has done is allowed us to do more Zoom meetings and disseminate information that we were not quite privy to do in the past because we didn't have all the technology.
Right. Well, thank you. I appreciate that.
Sure.
And I put that link that Dr. Fung just referred to in the chat, so everybody can take a look at that.
And what I was going to say is that the Ewing website is really good. It's not just NAS. Marcella Smith from Maternal Fetal Medicine that they use, she has a lot on the maternal side of things. And they have one on, there's so many resources on that website that I think would be good things for you guys to check out. We had a committee on maternal mental health. So there's a lot of resources there for moms with anxiety, depression, PTSD, things like that. So I would check out that Ewing website.
Dr. Fun, I had a question as well. This is Sean. I was curious, working in early intervention, we see a lot of the kids come home and either go to foster placements or have the non-maternal caregivers. And some of the struggles, just noting, is sometimes the kids will come home and being continued to be weaned using phenobarbital or another anti-epileptic. And we find a lot of times the caregivers really struggling with just the side effects of those medications. What's the usual course of determination to use those for withdrawals, and just kind of what's the decision that goes into that?
Yeah, so when we do send babies home on phenobarbital, we don't actually actively wean them. We just let them gain weight and sort of outgrow the dose on their own. So whatever dose they're sent home with, we usually just have the outpatient follow-up provider kind of keep track of what milligram per kilo dose as they weight gain. If it's usually less than 2 per kilo per day, you can then stop it. It takes about 6 to 8 weeks on the average to get off phenobarbital if you just don't actively wean it and just let natural weight gain be the weaning process. We don't usually send babies home on clonidine because there are some nuances on weaning, and you can get some rebound high blood pressure and high heart rate. So we really advocated not to send babies home on clonidine. They should be weaned off before they go home. But phenobarbital, it's many pediatricians are very, very comfortable with on an outpatient basis. So we are letting them do it. But yeah, I wouldn't actively wean. I just let them outgrow it. Does that help?
Yeah, that's helpful. It's sometimes we'll just see a lot of associated feeding difficulties with that, and have noted some of the kids, their growth has been a bit slower because of the reduced feeding. And so,
yeah. So I think if the baby is really sedated because of the phenobarbital, then maybe that would be one indication that you might want to come down a little faster. But that's something that we always keep track of before they go home, is that they shouldn't be sedated from the phenobarbital. It should just take the withdrawal symptoms away enough that they can feed. But if they are getting sedated, because it can, it has very, very long half-life, phenobarbital. So even if you start to taper down, it takes days for it to be completely metabolized in the body. So I would say if the baby is really sedated, do consider maybe coming down, a little faster than just allowing weight gain.
Perfect. That helps. Thanks.
Mm-hmm. I have a question for the audience. For as early intervention people, what are we missing from a post-hospital side that we should be doing better from the inpatient side. Anyone ready to tackle that? I feel like we do what we do in the hospital, and then it's like once they leave,
Yeah, I don't
we do
think-
okay.
Yeah, I think you don't like the whole dynamic of the family, that whole sort of what are their living situations like? Who are they going to be living with? And I know DCFS is supposed to be involved, okay, but their caseloads are high. And I sometimes feel that as a EI therapist and a NICU therapist, if I can reach out and talk to somebody in those programs and get them to represent those, I mean, it's the family. That's what we work with. And I know you work with it too in the hospital, but you don't see it. Like you don't see where they live.
No, and I think, the moms typically, they feel very stigmatized, so they actually don't want to be in the hospital, right? Some of the challenges we have to try to do this eat, sleep, console thing is that the mom is afraid of being in the hospital because they feel like people are staring at them, people are judging them. They don't really want to be there. So I would say, yeah, our interactions with moms and dads are a lot less than what you guys do on an outpatient basis. So one piece that I have been actually trying, so, I have all these babies in this eat, sleep, console protocol. What is so interesting is that I am losing them once they get discharged. So it's very nice that we can do these 2-year follow-ups and surveys. But once they, especially if they are, if they go to a treatment facility like Odyssey House or House of Hope, I'm actually losing some of these moms because they're not allowed to have phones, and so they can't fill out surveys. So I'm trying to improve that with some of these inpatient facilities. The other piece that I've lost hold of is, again, when these babies become a ward of the state, when DCFS takes custody, right now we're not allowed to continue studying them. So in fact, this Friday, I have a meeting with DCFS to try to change that process, because it's nice we can do this protocol, but if we can't figure out what they're doing in the long term, to me, that beats the purpose. So for what it's worth, I'm trying to change the system, but it's a uphill struggle at every step of the way. I'm sure you guys feel that.
So Quinn, I probably am going to pronounce your name wrong, but I see your hand up.
Yeah, Ching.
Ching.
Okay. Ching, yeah. My name is Ching. I work with Salt Lake County Health Department and the Nurse Family Partnership Program. I don't know if you heard about that, Dr. Fung. And we work with first-time moms. It's a long-term home visiting program, started in pregnancy till the baby's 2 years old. We do receive referrals from Super Rad and House of Hope, these places, but not as many as we want, And sometimes we get referrals from Super Rad, and when we talk with the clients about our program, they're not interested for some reason. Yeah. So
what does your program do? Sorry, but can you just
okay, we are nurses and public health nurses. We're in Salt Lake County Health Department, and what we do is long-term home visiting with high-risk families. Lots of teaching of education about everything, pretty much their life, their attachment, parenting skills, postpartum care, everything, and also connect them with community resources to achieve their goals, and case managing too, and that's a really big part of that. And a lot of times our nurses play the role as a therapist. So, this is this program has been around for over 40 years. in Salt Lake County. We started in 2008. Yeah. So
Do you have a contact information that you can put it in the chat or something so that
yep.
it's an excellent resource that we can refer moms to.
And
I know we Salt Lake County, but
yeah, exactly. And in Salt Lake County, we also have a sister program as parents as teachers. You know, so parents and teachers, because we have limits. We limited visiting just first-time moms. Parents and teachers, they can visit, you know, multiple kids at home as long as they have a kids under 3. They can visit them. It's about a 2 years program too. And also we have target case management, and those are the nurses go to see primarily the Medicaid and moms. And we sometimes receive referrals like these high-risk kids from hospital, but not as many. After I listened to your presentation, I feel like we should get more, but not really. Yeah. So that's a kind of an interesting thing. We just wanna, sometimes we kind of got a difficult to get access to the clinics, to hospitals, to educate them, to refer them to us. You know, like I guess a target case management, as long as they are on Medicaid and under 5 years old, they can refer to them. But for us, we had to enroll these clients before 29 weeks gestation. So I'll put my email there so we can probably chat more and get connected. Yeah. So fun.
yeah, and I think part of the challenge, at least I know personally, I can speak for, even though this is sort of my area of expertise, I still struggle to know what are all the community resources that are out there. And that varies, right? Depending on what county you're in, even what city you're in. And so I think as we all want to do better for this population, it's difficult to navigate all the community resources that are out there. I wish we could have a list of like all the places doing different things and kind of compile it into a that we can refer to.
Yeah. So actually, Dr. Jennifer Goldman-Luthi is creating that on the medical home portal. She is creating all those resources as well as highlighting that. And it's just I just appreciate you asking that question, because it is a critical time to be able to connect these families to get those resources. And we all need to do a better job of that communication between what happens in the hospital and the doctor's office, as well as that referral to early intervention. So I love that piece of it.
Well, and also I was going to say is that even our own hospital social workers, like, you know, we have high turnover there too. So somebody who knows exactly where to go when he or she is gone, the next person that comes in doesn't have that information anymore. So that high turnover of social works is also a barrier, I find.
Yeah.
Making sure that these referrals get done.
Well, we are at time, and I just really appreciate you sharing your information with us. It was a great presentation. We are having our next session on October 20th. We will be doing trauma and the art conversation. So please register and join us for that. If you haven't taken the poll, please, before you log off, take that poll, and we will see you. Have a great rest of your day.
Thank you for listening, everyone.